CAU is the acute receiving unit for Crosshouse Hospital. We take all GP referred patients here, and we take any emergency department patients who've been assessed as requiring medical review. The unit is divided into various different areas, each with its own patient cohort and function. Reception is where patients will arrive and are checked in by the staff. They will pull case notes, print off stickers, arrange any follow-up appointments, deal with relatives, and there's a fax machine here. Beside the reception is the waiting area where patients and relatives will wait. There's vending machines and patient toilets here. Within the waiting area there are red dot chairs, and this is where we will sit well patients who have had their initial assessment and who are waiting review to keep the initial assessment area as clear as possible. Beside reception there is the pharmacy with swipe access, and there is a tea room and male and female changing rooms with shower and toilet facilities. There are tea and coffee making facilities and a fridge in the tea room. Please make sure that you leave it tidy. And if you have any valuables, make sure that they're securely locked away in lockers. Behind reception is the initial assessment area. This is the area where all the work is done, and it's the busiest area of the unit. So all referrals go through the single point of contact phone call. We take GP referrals and emergency department phone calls here. The single point of contact band 6 nurse will take information regarding the reason for referral, the news score, any frailty scores, and they'll assess whether the patient has a red flag. Our red flags are a form of triage to assess whether patients will require urgent review on arrival, and we use that to stream our patients to decide which area they'll go to. Only GP referred patients come physically through initial assessments. The emergency department referrals will bypass and go straight to the area that they need to be. But once patients arrive in initial assessment, they're taken into a bay and they receive a news score, a brief history from the nurse, and relevant bloods, ECGs, cannula, ABGs, blood cultures that's been deemed as required. If the patients are well, then they'll often sit back outside, or they'll await transfer to the relevant area to be reviewed. We have an agreement that if a GP referred patient is deemed as very critically unwell when the paramedics pick them up, and they feel that they would require ED resus, they will divert the patient directly to the emergency department, where they will assess and treat and stabilise the patient. Thereafter, we will take them if they're still suitable for medicine. If a patient arrives, however, and are physically in initial assessment and they're unwell, we deal with them in the unit. The initial assessment's divided into a few cubicles. There's cubicles 1 to 3. Currently there are 2 clinic rooms. There's what we call the resus room, which is not truly a resus like ED, but has some emergency drugs, an NIV machine, some equipment if stabilisation is needed, and some bedside monitoring. So we tend to move the more unwell patients in initial assessment into here. There's also a room that we call the Dvt Room. In total there are 7 spaces, and when it's busy we'll often have patients on chairs or trolleys. Ideally this area is really to do a very brief initial assessment of the patient and therefore thereafter stream them into the right area. But when it's busy, patients may wait in here for a while and you may need to clock them in this area. If a patient's arrived and their news is high or they have a red flag, the nurse in charge will page the first on to assess the patient. You can document this on the back of the yellow sheet. This is the initial assessment document where we take all the information for referral. If they require any urgent treatment such as fluids or antibiotics, please ensure that you hand these over to the nurse looking after the patient personally, because it's a very busy area and we need to have good communication skills when it's very busy and patients are unwell. Within the initial assessment area there is the e-whiteboard, there's a physical whiteboard, and there's the nursing staff who'll be able to tell you where the patients are within initial assessment. The case notes are kept in folders at the desk, and there's also where we house the telemetry for the unit. There'll be a separate session on how to use the telemetry, and there's also a folder there which instructs you. But our telemetry channels are patient held and they each link to a phone that's carried by the nursing staff. Moving through to rapid assessment, this is an area with 6 reclining chairs and 4 physical chairs that is open 7 days a week from 8 a.m. to 8 p.m. This is where we move and assess patients who we think are likely to be turned around same day, very well patients, low risk chest pain, pleuritic chest pain, headaches. We stream patients directly to rapid assessment, and this is manned by the acute receiving team Monday to Friday with a specific consultant. We try and turn around patients very quickly and assess them. Rapid assessment is also where the DVT service runs, largely run by our acute medicine ANPs, but you may be asked to assess some of the DVT patients, and we have pathways for that. The other side of rapid assessment is the ambulatory care unit. This is more of a short stay unit. We have 11 cubicles with beds in, and it's shared between the acute medical team and the emergency department. The emergency department will have patients on their pathways such as renal colic, anaphylaxis, post-sedation. The rest of the beds are for medical patients who maybe need an overnight stay, for a troponin in the middle of the night, or a thunderclap headache assessment. There's a separate nursing base here with the nursing notes and a whiteboard up on behind the nursing station where you can see the patients that are here. It's also manned through the daylight hours by one of our acute medicine AMPs who know the system inside out and will be your best friend if you need any help there. There's also access through the ambulatory care directly into the emergency department. So if patients have a long wait in the emergency department, you can get access that way to see them through in the unit. The main part of the ward is a large square. We call this the bedded area, and this is 35 single rooms where patients who are likely to need more than an overnight stay or admission to hospital are streamed. They may be GP referrals from an initial assessment or directly from the emergency department. Because it's a large square, it's divided into 4 zones. The 4 zones each have separate colours. 3 of them have 10 beds, 1 has 5. Orange, lime and pink each have 10 beds, and yellow has 5. Each zone has its own colour behind the staff base, their own nursing staff, and their own trolley where all case notes are kept. On each door you'll see a coloured plaque denoting the colour of the zone, as well as behind the nursing base. Each zone also has the e-whiteboard so you can see the patients that are in that area. In each zone we also have a pod system to pod samples to the labs. Please ensure that you don't put lumbar puncture or blood culture samples in this tubing, and there's instructions on how to use this at each zone. Because of the layout of the unit, when the emergency buzzer goes off, it's not possible to see the light in all areas. Therefore, at each zone we have a panel. If you hear the emergency buzzer go off, please look at the panel on the wall and it will tell you which area that is. The emergency and arrest trolleys are kept at opposite sides of the unit. So there is one at lime that covers lime and pink zone, one at rapid for orange, rapid and yellow, and one in ambulatory care which covers ambulatory and initial assessment. The arrest trolley in rapid assessment also has the IO gun. That's the single one for the unit. If you need any emergency drugs that are not on the trolley, these are all kept in the initial assessment drug cupboard, such as TPA, atropine, etc. We also have an arterial blood gas machine that's housed in the sluice in yellow zone. If you're not familiar with using it, please ask the nurses and they'll show you how to use it. We also have drug prep rooms. These have fluids, cannulas, dressings. We also have a to take out cupboard. Whilst we have extended pharmacy hours Monday to Friday for immediate discharges, at the weekend at present there is a limited input from pharmacy, and therefore you may need to dispense to take out medications from the unit. We've deliberately limited the stock in these cupboards so that we're not giving out non-routine medications. But within the cupboard there's a folder that shows you the process that you should follow to dispense medications. Please make sure that you're following it and document things to limit errors for patients. The emergency exits are highlighted in the unit and here shown on the map. The fire alarm test is every Wednesday. Each morning at 8:30 we have 2 ward rounds of the patients who've been admitted overnight or the previous evening. They tend to start 1 consultant in orange and lime, 1 consultant in yellow and pink. If you've been on overnight, we'll expect that you join the ward round at 8:30 until 9:30 to present any patients that you've seen and to learn from the ward round and hopefully get some supervised learning events. If possible, try and figure out where the majority of the patients you've seen are and join the relevant ward round. It may not always be possible if you're seeing patients in the emergency department to get many, but we'd still want to ensure that you join the ward round and learn from it. There's also the frailty team that will have input on selected patients, and there's a further acute medical consultant ward round that covers ambulatory care and rapid assessment. So if you have patients in ambulatory care, you can always join their ward round. This tends to start closer to back at 9. Each morning at 9 o'clock we have the medical handover, so the night shift senior and a member of every team's day team is expected to come at 9 o'clock every morning. So the day before, you should allocate within your team who's coming to the huddle, and on your way into the building, come into the seminar room and receive a hand back from any patients from your team that you need to know about. This usually takes a maximum of 10 minutes, thereafter you can join the ward round. We also follow that with the cardiac arrest huddle, where team roles are allocated, a checklist has gone through and everybody knows their roles when they come to an arrest through the day. Morning handover is attended by an acute medical consultant who does take a record of attendance from Monday to Friday, and the handover does occur at weekends, although there's no consultant present at the moment. The seminar room is also where the evening 9:30 hospital at night meeting handover happens. So if you're on night shift or if you're handing over to the evening, you should come to the seminar room for handover. There's also a further cardiac arrest huddle after the evening handover then as well. The seminar room is also where we have lunchtime teaching. You're all welcome to come along to the acute medical teaching sessions on a Thursday. Particularly, we run a few on HDU type situations such as vasopressors, NIV. You're all welcome to come along to those sessions and you receive information about them. Next to the seminar room is the patient relative room. This is a small room that you can use if you need to speak to relatives away from the bedside. Please make sure you don't leave any valuables in the seminar room, as the room is used frequently throughout the day and you may not be able to access them, as well as it not being secure. All entrances to CAU are swipe card access, so please make sure your swipes work before you're down here for your first shift. There's entrances by reception. There's also a back entrance. The corridor beside the labs is the back entrance into the unit if you need that. The acute medical consultants have an office that we all share towards the back entrance of CAU. You can find the ward round laptops here if you're the FY1 on the ward round. They're stored in here along with the passwords for them. This is where you'll also find many of the acute medical consultants. If you have any questions throughout the day, please feel free to chat the door and come and have a chat with us. But we're usually on the shop floor most of the day, most days of the week. The majority of how we work is centred around the electronic whiteboard. This is how you know which patients are new, which patients need clerked in, which patients have had a consultant review. It gives you a time order of patients to see. We'll have a separate session on that so you know exactly how to use that prior to you starting. We're looking forward to having you all. We'd like you to come and have a look around the unit before you start. If you've got any questions, please feel free to ask. The Athena page has a wealth of protocols and knowledge. There's also the CAU handbook. And if you have any questions or any feedback or any suggestions you want to improve, please make sure that you just come and find us and ask.